This briefing will distill the practice-changing updates from the 2026 Chinese CML Consensus. We will focus exclusively on the high-impact recommendations and new algorithms for immediate clinical application. We'll proceed directly through 6 key sections, starting with the core paradigm shift, moving to risk-adopted TKI selection, new toxicity management algorithms, updated TFR criteria, protocols for special populations, and finishing with a summary of the Class 1 and 3 recommendations. All right, first up, Section 1. This covers the fundamental shift in the CML management paradigm. So the central shift is this. We're moving from just disease control to quality long-term survival. The consensus formally shifts our primary therapeutic goal away from achieving molecular milestones alone. The new focus is on optimizing long-term, high-quality survival, which mandates integrating patient-reported outcomes into the entire management framework, constantly balancing efficacy against tolerability. So what's really new here? A few key things. First, the STMI inhibitor asciminib now has first-line approval for CMLCP, supported by the ASSEMBLE trial data. Second, there's a huge emphasis on the ELTS score. It's now the preferred prognostic tool because of its superior predictive power for CML-specific mortality over SOCL and URA. Third, you'll see the criteria for treatment-free remission, or TFR, are much more stringently defined. And finally, the consensus gives us formalized algorithm-driven pathways for managing key toxicities and specific patient cohorts. All right, let's move on to Section 2. Here, we'll cover the mandatory initial assessment and how we make risk-adapted first-line TKI selections. For the initial workup, a few things are mandatory. Of course, you have your standard hematologic and cytogenetic analyses, with quantitative BCR-ABL1 on the international scale as the critical baseline. Risk stratification is a must, with the stated preference for the ELTS score to identify high-risk patients. And a new required step is a comprehensive baseline comorbidity assessment before selecting a TKI. This matrix really dictates first-line TKI selection. For your ELT's high-risk patients or those targeting TFR, second-generation TKIs or asciminib are clearly preferred over imatinib. You'll want to avoid nilotinib in patients with high cardiovascular risk. For dasatinib, you need to use caution if there's significant pulmonary comorbidity. And finally, for planned pregnancy, imatinib or nilotinib are the preferred options, while dasatinib and asciminib are contraindicated. Okay, on to Section 3. Here, we're going to detail the new algorithm-driven protocols for managing key TKI-related toxicities. Let's start with the hematologic toxicity algorithm. The rule is simple. Any grade 3 or 4 cytopenia means you must suspend the TKI immediately. You can only resume therapy once the patient has recovered to grade 1 or less. The decision to resume at full or reduced dose is strictly determined by the duration of the interruption, with specific cutoffs for each agent. It's also worth noting that off-label use of growth factors can be considered for symptomatic support. Now, for the cardiovascular AE algorithm, the key word is proactive. A pre-treatment risk assessment using a validated tool like SCORE2 is now a Class 1 recommendation. For any patient classified as high or very high risk, both nilotinib and ponatinib are contraindicated. For patients on these agents, periodic screening for peripheral arterial occlusive disease via ABI or duplex ultrasound is strongly recommended. The pulmonary toxicity algorithm is really focused on dasatinib-associated pleural effusion. Management is graded. Grade 1 effusions can be monitored, but any symptomatic effusion or even an asymptomatic grade 2 requires immediate TKI interruption and initiation of diuretics with consideration for corticosteroids. And here's the hard stop. Recurrence of a significant effusion after dose reduction mandates permanent discontinuation of dasatinib. Okay, moving on. Section 4 outlines the updated strategy for dose optimization and, very importantly, the stringent criteria for attempting treatment-free remission. So the central question we're answering here is this: when is treatment-free remission a viable goal? We need to define the precise eligibility criteria and the right timing for attempting this functional cure. TFR eligibility is very strict, and it's based on data from trials like STIM and EuroSki. The patient has to meet all of these criteria. First, minimum TKI duration is more than 5 years for first-gen agents, or more than 4 for second-gen. Second, they need a sustained deep molecular response. We're talking MR4 or better for at least 2 years. And finally, any history of TKI resistance or having been in an accelerated or blast phase is an absolute contraindication. No exceptions. Now, for the patients who do meet these criteria, the data is pretty solid. Multiple large-scale trials confirm a durable TFR rate of about 40 to 50%. But it's absolutely critical to remember that if they lose major molecular response at any point after stopping, that mandates immediate reinitiation of TKI therapy. Let's turn to Section 5 now, which covers the necessary management adjustments for special populations. Specifically, we'll look at the elderly, women of childbearing potential, and pediatric patients. As you'd expect, management priorities really diverge in these populations. For your elderly or comorbid patients, the primary goal is safety and tolerability. Decisions should be guided by a comprehensive geriatric assessment, which might even support an initial dose reduction. On the other hand, for pediatric patients, the absolute priority is preserving normal growth and development. This means routine monitoring of growth velocity, bone mineral density, and pubertal progression is mandatory. For the algorithm managing patients of childbearing potential, the ideal pathway is achieving TFR before conception. If a patient does conceive while on a TKI, you stop the drug immediately. Interferon alpha then becomes the preferred therapy for disease control. Now, after 16 weeks gestation, if you see a loss of complete hematologic response, you may warrant a cautious reintroduction of either imatinib or nilotinib. But let's be clear, that is a high-risk decision. And finally, let's consolidate all of this into a clinical checklist. Section 6 covers the key Class 1 and Class 3 recommendations. So let's break this down. Your Class 1 or must-do recommendations are 1. Standardized IS monitoring, 2. ELTS risk stratification at diagnosis, and 3. Pre-TKI comorbidity screening. Now for the Class 3, the must-avoids. That's nilotinib in high cardiovascular risk patients, dasatinib in patients with significant pre-existing pulmonary disease, and of course all TKIs during the first trimester of pregnancy and during breastfeeding. This leaves us with a final question. As we integrate these guidelines, we have to think about how our own clinical workflows will need to evolve. How can we systematically capture patient-reported outcomes and better utilize digital health tools? The goal is to move CML care away from being just protocol-driven and toward truly predictive and individualized management. And that's really the core message of this consensus.